Hello, good morning, good afternoon, good evening, wherever you are. Welcome to NCER's webinar, Tracking Lives in Livelihoods Through the Pandemic. I'm Sonalde Desai, a professor at NCER. I also direct NCER's National Data Innovation Center. As you know, NCER's National Data Innovation Center has been undertaking periodic telephone surveys throughout the pandemic to provide real-time data on challenges facing the society. But today, we bring you a very different presentation based on in-person interviews with residents of the Delhi-NCR region that began well before the pandemic. We returned to the same households in late 2021 to reconnect with them and to see how their lives had been shaped by the pandemic. As you hear us present both the resilience of Indian economy and challenges in the years ahead, please remember, we are speaking from the vantage point of Delhi-NCR. This is a unique region, more privileged than many other parts of the India, but it also suffered from the pandemic to a far greater degree than parts more distant. Today's presentation is a chorus with many of my colleagues, Santanu Pramanik, Reem Ashraf, Ruchi Jain, Abhinav Motheram, Debasis Barik, Pallavi Choudhuri, and Manjistha Banerji. So without further ado, let me turn to Dr. Santanu Pramanik, Deputy Director of National Data Innovation Center, to introduce the study. Santanu?
Hi, thank you, Sonal, and good evening, everyone, and good morning and good afternoon as well. So let me share my screen. Sonal, you can see my screen, right?
Yes, I can.
Okay. Yeah, so as Sonal mentioned, we'll be talking about results from Delhi Metropolitan Area Study, particularly to understand particularly we'll be presenting the findings from DMAS, Delhi Metropolitan Area Study, in understanding the impact of the pandemic on people's lives and livelihoods. So DMAS was launched, as Sonal mentioned, way before the pandemic. So we launched DMAS in 2019 with the baseline survey. So after that, we had multiple rounds of follow-up surveys till the pandemic hit the world and India as well. So then we couldn't complete the study, for couldn't do any data collection for about 1.5 years or so. But after the severity of pandemic had receded, we were able to complete the study with the end-line survey. And so here we are with the results from that study. This is a joint, this is a collaboration between National Data Innovation Center and the Survey Research Operations at University of Michigan. And I'd like to mention a couple of team members' name in addition to those who will be presenting today or in the panel today. So Vijay Chauhan and Dinesh Tiwari, without their invaluable contributions, this study would not have been completed. So DMAS was originally planned as an incubator to experiment with innovations in data collection. So this is not the usual type of objectives you would see in many in most of the studies and surveys. So in that sense, DMAS was quite unique. So innovations were around technological innovations as well as innovations in questionnaire designing. So technological innovations include Cappy, computer-assisted personal interviewing. I mean, Cappy, of course, is no longer an innovation because even in Indian context, I mean, most of the surveys these days are being conducted in Cappy. But the one novel aspect of DMAS was that we tried to use the maximum amount of paradata that are being generated through Cappy surveys and use that for remote monitoring of data collection activities as well as for quality assessment. So that was kind of the novel and innovation part of our survey. We also had a CATI component where we tracked individuals, men and women of working age group, to get a sense of their employment pattern, the fragmented nature of employment pattern. So this was done well before the pandemic. I mean, during the pandemic, of course, the mobile phone service became very common, but this was implemented well before the pandemic, starting in 2019. And also we had a ECASI component, audio computer assisted self-interviewing, which is a very novel mode of data collection in collecting better data for sensitive topics. And it is well known that it can lead to better reporting compared to surveys involving interviewer administered surveys. So here, the ECASI we use to capture contraceptive use data, where the respondent listened to the pre-recorded questions through headphone and then recorded answers in the laptop on their own without any intervention from the interviewer. So there are a range of innovations in around questionnaire designing that we have implemented throughout this study, but I'm not going into the details of that. Just a couple of points I'd like to highlight that we tried to include topics to adapt to the changing socioeconomic conditions. So topics like digital literacy, financial inclusion, etc., are worth mentioning. And also, it's designing a survey for a CAPI versus designing a questionnaire for a paper-based mode of data collection is a completely different ballgame. So that is quite a learning for us, and we tried to sort of make the most of that during this study. So here, more formally, the 4 key objectives of DMAS. So I'd like to just talk about the last point. So one of the objectives was to mainstream some of the best practices that we learned from DMAS into existing data collection efforts in India, but that's never easy task. And but we tried to engage with various stakeholders and disseminate some of the findings we have, the approaches we have taken. But one thing I would like to mention that we are actually using the similar type of approach and the softwares and the programming approach for India Human Development Survey, which is a nationwide survey. So we're making the transition from DMAS to, which was based in Delhi NCR only. So now to the national level survey. So that's an achievement in itself. So for DMAS, the target population was the National Capital Region, which, as you know, it's not only includes Delhi, but also surrounding districts from the states of Haryana, UP, and Rajasthan. So when I say Haryana, UP, Rajasthan, I only mean the NCR part of Haryana, UP, and Rajasthan, not the entire state. So just we have to keep that in mind throughout the presentations you will be listening today. And we adopted a 3-stage stratification cluster sampling design at baseline to recruit the households in our study. And we also constructed survey weights to account for the differential sampling rates. And I think almost all our presentations or the results you see today, those are all weighted estimates. At baseline, we were able to complete about 5,250 households, which include more than 27,000 individuals. And to implement the survey, we have used a software called Blaze, which is developed at Statistics Netherlands. So we used it for Cappy, CATI, and ECASI part of the technological innovations that I just mentioned. In addition to Blaze is mostly used for programming the questionnaire into Cappy, but that was not enough. In addition to that, we also used software called Survey Track, which was developed at the Survey Research Operations at University of Michigan, known as Survey Track, so which is used for sample management and survey management a part of the survey. So this is Delhi NCR map. You all know about it. And so just one point I'd like to highlight. I mean, from the name, it may seem like it's an all urban survey, but it's actually not. As I said, like it includes districts from Haryana, UP, and Rajasthan. So we have a sort of equal mix of urban and rural households in our study. Here's the process flow of the scientific data collection process that we have followed, and as well as the survey implementation process. I mean, we sort of think both are equally important, and we try to sort of give equal importance and rigor to both the processes. So I skip this slide. That's just wanted to highlight that. One point I'd like to mention in the context of Cappy sort of designing, developing this Cappy reference questionnaire is very crucial. It's not just the paper questionnaire. You cannot use that for programming of the questionnaire. We need to develop a Cappy reference questionnaire, which is quite an extensive amount of work, so that the programmer actually understands what we want and how we want to sort of design the survey into Cappy. Okay, so now let's see the sample characteristics of the households who are part of the DMAS study. So here we presented the distribution of the sample across different states, NCR part of the states, area of residence like rural versus urban, across religion categories, caste categories, as well as economic status. So if you'll see the last column, so that's the non-response rate between baseline to end line. And overall attrition we have seen is around 18%. But this non-response is not at random, because if we see that for Delhi, the non-response rate is much higher, 31% compared to the overall 18%. And it's higher in urban areas, 30%. And also it's higher among the richest wealth quintile households. So that's kind of known to us in face-to-face surveys that we have seen in earlier studies also. So just wanted to mention that. And also on the right side, the table you see is the different type of attritions that we have seen at DMAS end line. So out of so about 6% households are out of sample. That means they no longer leave. During baseline, they were in the NCR region, but they no longer live in the NCR region. So it could be because of the pandemic, they have moved out to their native place or something. So that's something I wanted to mention, and the rest are refusal and other type of non-response. So now just at the individual level, these are the sample characteristics of the individuals across gender, age group, marital status, and educational attainment. So here, I think the gender distribution is more or less even, and age group distribution also, I think it's very similar what we get to see for India. And the education part, if you see the never attended school, about 24% of our sampled individuals never attended school, but it actually includes the 0 to 6 age group as well. If you leave that out, then also we'll have around 11% of our sample sort of never attended school. So at least our survey cannot be criticized on the ground of 100% literacy rate. So that's so it's pretty sort of evenly distributed in terms of educational attainment that you get to see in India. And on the right panel, if you see the flow chart, so here we tried to track the individuals who were at baseline. Where are they now at end line? So basically, 4,000 out of 5,253 households at baseline, 4,292 participated at end line, and that includes about 23,008 individuals at baseline. Out of those, 998 are now part of the split households, 821 are migrated out, 488 individuals died, and and 204 were wrongly added, and 2166 new members added. So if you just do the algebra, I mean math, you'll get exactly the same number that we have at end line. So this is all sort of in summary. This is about all about DMAS, and I'll stop here and I'll let you dive into the more interesting part of the presentation. That's the findings from the study.
Thank you, Santanu. I'd like to now ask Dr. Reem Ashraf to talk about some of the interesting results from DMAS.
Thank you. Hello, everyone. So in the inline survey for DMAS, we also asked questions on subjective perceptions. One of the questions asked was regarding the initial lockdown. Can you just change the slide?
Yeah, just a second.
Yeah. So the question in retrospect asked was, when the pandemic began, the government announced a nationwide lockdown on 24th March 2020, which continued for more than 2 months. Now, taking everything into consideration, do you think it was a good decision or a bad decision? The option categories on a scale were if it was considered to be, if it was perceived as a good decision, a bad decision, or no opinion. We see in retrospect for NCR, 71.4% actually perceived the national lockdown during the early phase as a good decision. 26% thought it was a bad decision, and remaining 3% have no opinion regarding it. We also further delve deeper, seeing it across different parts of NCR and across rural urban areas. In Delhi, 64% people perceived it to be a good decision as compared to other states, where the percentage of people who actually perceived it to be a good decision is far higher. In Delhi, 33% people actually thought it to be a bad decision in retrospect, which again is the highest reported percentage if compared to other part of NCR, where a less number of people reported it to be a bad decision. If we see to the rural and urban areas with respect to the perceptions on the early phase of the lockdown, the results on perception remains more or less synonymous for rural and urban areas. Further, we looked at the perceptions across different economic categories. The results on this resonates with the intuitive understanding of the situation, where 32% of the poorest of all perceived national lockdown in retrospect as a bad decision, as compared to the richest, where only 12% have perceived it as bad. 86% of the richest again perceive it to be a good decision, and this proportion gets down considerably as we go down the economic ladder. So this is all on the perception and the subjective understanding of national lockdown that we have for our DMAS. Thank you.
Thank you, Reem. I think we have to put this in the perspective that 64% of even the poorest actually think that this was a good decision to impose the lockdown. Part of it is because this interview was done between August and November of 21, after Delhi has undergone the severe Delta pandemic and suffered through it pretty desperately, right, making people see the seriousness of the disease. Thank you. Our next presenter is Dr. Ruchi Jain, who is going to talk about testing and during the pandemic. Please go ahead.
Yeah, thank you. Good evening, everyone. So I'll talk about the numbers tested, test positivity, and the ones who were infected with COVID-19. So we have asked 2 questions in our survey, one under testing, which is, have you or any member of your household ever been tested for COVID? And the second one for the positivity, that is, which of the following household members tested for COVID? So as Santanu said, we had about 4292 households in the inline survey, which comprises of 22,663 individuals. So out of these individuals, about 21 were tested for COVID and 7% were found to be infected. So last one, please, the earlier one. The frequency of characteristics of cases was described by age of the respondent, their education, place of residence, and the Venn quintiles. Next one, please. So if you look at this table shows the numbers tested and the positivity rate. So if you look at the age, you can see that the testing rates were almost similar for all the age groups. But if you look at the positivity rate, it was higher for those in the middle age group people, that is 45 to 59 and 60 plus, and which is, I think it's, which is quite similar with the other findings too. So there was no significant difference observed by gender, both for the testing and the positivity rate. So the testing rates were higher for the better educated, for the urban and richer people, and which is quite, I think it's expected because they had better testing facilities. But however, it's surprising to see that the testing rates was also higher for this age group, this group of people. Maybe because, maybe the next one, please. The World Bank data says that urban areas are the hardest hit as due to high density of population, which results in higher spread of the disease. Some of the other studies shows that people living in low and middle income countries, they have been exposed to various pathogens from childhood, which leads to lower infection rates. And one of the studies, they have compared data from 106 countries, which says that people in poorer, low-income countries seem to have higher immunity, which leads to lower infection rates. Next one, please. We have also looked at the severity of COVID-19 infection, and the graph shows that about 2/3 of the population, they had mild infection, about 1/4 were moderately infected, and 1 in every 10 person had severe infection, and which is quite significant. We've also tried to look at the severity by age group, and what we found that the infections were a little severe in the middle age group. So that's all from the numbers DMAS perspective. Thank you.
Thank you. Now that we have heard about the prevalence of disease in testing, the next presentation is by Abhinav Motheram, who is going to talk about vaccination in Delhi-NCR region. Abhinav?
Yes, thank you, ma'am. Hello, everyone. So I'll be walking you through the top line results on vaccination from the DMAS inland round of data collection. So Shantanu had earlier described the sample characteristics of DMAS overall, but for vaccination module, so during the survey time period of August to November 2021, vaccination was only open to individuals 18 years or above. So our analytical sample for this particular analysis is about 15,285 eligible individuals. So the first question we ask here is did any member of your household receive a COVID vaccine? And the results are that 81% of the households reported to have at least one member of their household having been received COVID-19 vaccination. So this is a sort of our screening question, and based on this question, we probe the vaccination status and details of the individual members. And on the right side, this is kind of an interesting graph. So what this shows is the proportion of eligible members in the household who are vaccinated with at least one dose. And the interesting result is that about 43% of the households report that all eligible members of their household have at least one dose of vaccination. And the graph you see is bimodal. 0 on the left side you see 0% proportion, and on the right side all eligible members are about 43%. This is interesting because vaccination is widely perceived to be sort of an individual choice, but clearly and there are some household effects, and we have some ongoing research in this area to establish the results more concretely. Yeah. Next graph, Shantu. Next slide. Yeah, and for the now on the details of the vaccinated individuals. So 63% of all eligible adult members have reported to have received at least one dose of vaccination. So these are about 9,791 of the earlier around 15,200 adults who have reported at least one dose of vaccination. And for these particular groups, we ask we probe the details on their vaccination, and basically 3 questions in particular. First, we see that majority, we ask them what was the vaccine they received, and majority, about 77% received Covishield, about 10% received Covaxin. And interestingly, here we also see that about 14% of the respondents, they said that they do not know which vaccine they received. We find this a bit interesting, and we also have some more research on this going on. Further, we asked them how many doses they have received. About 39% said they are vaccinated with both doses. About 60% said they are only vaccinated with one dose. Then then we asked them if they've experienced any serious health issue or was needed to be hospitalized within 10 days following the vaccination. So our question here is in line with the severe or serious events as per the state guidance document for AEFI surveillance. And about 1.8% reported to have experienced a serious health issue or was needed to be hospitalized within 10 days. So, and also the results here are in line with national AEFI numbers. Then finally, for if at least one member of the household is not vaccinated, we ask what were some of the reasons. We ask them about 13 reasons. We give them 13 reasons as to why didn't the member of the household not take the COVID vaccine. And here we list some of the major key reasons. Primarily, about a quarter, 24% reported they were planning to be vaccinated soon. So this is important because vaccination at the population level is a fast-moving parameter. So some of them might have been vaccinated after the interview. About 15% cited pre-existing health conditions as the reason. Another 15% reported lack of trust in vaccine efficacy or safety. Then about 9% said they're worried about side effects of vaccination. So these are the top line results on vaccination. I would now hand it over to Debasis to talk more about health and healthcare in more broadly.
You know what is interesting about these results, Abhinav, is that the survey occurred between August and November. So vaccination was still sort of in early phases. And even so, we see 81% who received at least one dose or within their household. So that's quite impressive. And it kind of gives us a little bit more faith in the vaccination numbers that we are seeing from some of the national reports that are coming through. The next presenter is Dr. Debasis Barik, who's going to talk about other health effects associated with the pandemic. Debasis?
Yeah. My previous speakers, Ruchi and Abhinav, have actually discussed the health impacts of COVID-19 in terms of infection and treatment. So my presentation will focus broadly on the management of non-communicable disease during the pandemic. Next slide, please. So the scientific community has recognized that pre-existing cardiovascular and metabolic health conditions seem to be linked to worse health outcomes COVID-19 itself can also induce various cardiovascular and metabolic health conditions like myocardial injury, arrhythmia, hyperglycemia, etc. post-recovery.
Excuse me, Debasis, sorry for interrupting, but could you speak a little more loudly? You're coming through very faintly.
Sorry. Now is it okay?
Yes, this is excellent.
Yeah. So, two recent studies published in Nature Reviews Cardiology and Nature Reviews Endocrinology, those focused particularly on the issues of this post-COVID implications on non-communicable diseases. So, as we know, there was certain level of disruptions of routine healthcare services during the pandemic. It would be imperative to know how people in Delhi-NCR region were also able to manage treatment of these non-communicable diseases. So we had the opportunity to study both the changes in prevalence and treatment seeking for these illnesses after the deadly second wave of infection. Next slide, please. So here actually I will walk you through the questions we asked in DMAS survey. So in both baseline and endline survey, so we had a health roster that was separately actually asking question about various long-term and acute health conditions for each member of the household. Then details of their treatment seeking was recorded for each episode of outpatient visit. Those who did not visit a doctor or a health facility, even if suffering from the illness, were asked if they were already having some medication for these illnesses or not. So in the current study, we have basically measured non-treatment or non-treated cases are those where the person have actually told about having an illness condition who neither visited a doctor nor were they taking regular medicine. So specific questions asked were, did NAM seek treatment for this illness in last 15 days? Yes or no? If no, then we had an additional question, why did not NAM seek treatment for this illness in last 15 days? And one of the options there was the person is already on medication. Next slide, please. So now going through the results. So what we find that between baseline and endline, so there was a significant increase in prevalence of high BP. As you see from the figure, in baseline, we find around 3% of the population who reported of having high blood pressure, and that figure increased to 4.4 in the baseline endline. But for the other two health conditions, chronic cardiovascular disease and diabetes, we did not see much changes during the same period. Next slide. Yeah. So this slide focuses on the treatment-seeking behavior for these health conditions. So here we find that basically for cardiovascular disease and for high BP, there was a significant increase of untreated cases between baseline and endline. So for CVD, it basically persons who did not sought treatment for these conditions rose from 1.7% to 8.6%. This is quite a big jump. And for high BP, this basically rates rose from 2.2% in baseline to 8% in endline. That's all. Next. Thank you.
Thank you, Debasis. This is a topic to which we should return when we start discussing some of the results. It has tremendous implications for the future of health services delivery and even healthcare financing. So moving on to employment, what the DMAS data show us is that there has been a recovery in employment after the initial decline during the lockdown period. But at the same time, this is a fragile recovery. Next slide, please. So we, as Santanu mentioned, we had monthly telephone surveys in which we asked people, one male and one female of the households in which we interviewed, to give us contemporaneous information about how much work did they do last month, whether they participated in wage work, in business activities, farming, caring for animals, etc. And what you see is that there was a very sharp drop in work participation rates during the initial lockdown, which was around April and May of 2020. Okay. By the time the second wave of the pandemic emerged, which was April and May of 2021, we do see some drop in employment, but it was a smaller drop. And the employment seems to have, by the time it was September of 2021, had kind of begun to recover with some slightly, a little bit less than before, but more or less close to the levels as seen before. This was sort of a smaller sample, only about 2,200 men and women. So let me present data in the next slide from a little larger sample, okay, where we also see that work participation rate in pre-pandemic period, which is 2018-19, and post-pandemic 2021, okay, is almost similar, with a slight difference of about a couple of percentage points for men and almost none for women. Okay. The decline is statistically significant, but it's extremely small. I think, though, the one thing I would like to submit is that we should not treat this as thinking that economic impact was very small. Okay. Next slide, please. As we start thinking about specific kinds of experiences, we start seeing that there are a couple of areas in which the employment has been substantially affected. First, average number of days that were worked in the 12 months before and after the onset of pandemic fell by roughly about 30 days for men, by about 20 days, 10 days for women. So during the period when the lockdown occurred and people could not get to work, the incomes would have declined because of this period when they couldn't work. Okay, and we'll see those results in a few minutes. Next slide, please. More important, though, I think there was a real destabilization of work as individuals, particularly women, scrambled to cope. India is not a country where employment is an option, unemployment is an option for many people. And so when you cannot do one kind of a work, you sort of turn around and do something else. And what we find is that when people could not continue with their business, they sort of started working in as agricultural laborers, or doing some sort of a small job of car washing or any other kind of a small job in their neighborhood. So if we think in terms of being able to continue your prior activity as something that provides an employment stability, we see actually substantial amount of destabilization. People who worked in farming, men were most likely to continue. About 82% of the men who were cultivators continued to cultivate. Salaried workers, about 73% of the men continued in salaried work. And I would remind you that we are talking about Delhi-NCR region, where there is a substantial proportion of workers are government workers who were not affected in terms of losing their jobs during the pandemic. Casual laborers actually were affected substantially, and many of them had to sort of start thinking about other things to do, and quite a few sort of returned to family farms and allied agricultural activities. Among men, the biggest impact was people for business owners. During the pandemic, when the businesses couldn't open for 2 or 3 months, there were some of the very small business owners or micro enterprise owners found that they could no longer continue, and they shut their doors and then started looking for other kind of work. So only 61% of the men who were engaged in business before pandemic continued to do so. For women, we see a slightly different pattern. Farming is protective for women as well as for men. But the salaried workers, only about 63% of the women who were salaried workers continue to do salaried work, as opposed to men of whom 73% continued. Substantial proportion of casual laborer women and business owners did not continue. But here I would urge caution, because the number of women who owned business and participated in home-based business is relatively smaller compared to the men. Next slide, please. So I think in summary, what I would like to say is that we need to think in terms of, we should rejoice in the fact that employment has rebounded. We should also think in terms of long-term scarring that might have been left behind, particularly for the households which suffered an income loss when they couldn't find any work. They might have gone into debt. And for employees, or for people who were continue to work, there may have been a destabilization in terms of business closure or loss of higher quality salaried job and being replaced by lower quality casual work, particularly for women. So I think we might want to think about these long-term vulnerabilities as we go along. Thank you. Next, I will turn to Pallavi Choudhuri to talk about changes in consumption and food intake. Pallavi?
Thank you, Sonal. So I'll be presenting on aspects of well-being through the lens of consumption behavior. As Sonal pointed out, and as he observed, that there was a very fragile recovery, and there has been some long-term repercussions, particularly for casual wage workers and businesses. So what we will do here, we will take a look at how consumption evolved, how per capita consumption evolved between the two periods, between 2019 and 2021, so pre and post-pandemic. Now, what we observe is that real per capita consumption dropped by about annual rate of 4.7% between the two periods. And these values for the 2021 values have been adjusted by state level, sector level disaggregated CPI, Consumer Price Index numbers. And the drop in per capita consumption, though, was mainly driven by discretionary consumption items, whereas consumption in food and non-food essential items were relatively anchored. They remained relatively stable over the two time periods. Like non-food essential items dropped by around 1.2%, but food consumption actually increased a little bit by 0.8%. But the difference between the two periods is so trivial, and it's not really statistically significant. And this consists of the matched panel of 4292 households that we surveyed for both the rounds. Next slide, please. So now here we delve a little further, we deep dive into certain aspects of consumption, and especially those that were backed by the government extending its welfare package, which began from April 2020, when the announcement was made in March 25, 2020, but the relief package was extended well into 2021. So what we observe is that the per capita cereal consumption was very stable over this period of time. So rice consumption was 1.5 kg before, it's 1.6 kg after. The wheat consumption is like it was 7 kg before and 6.6 kg after. And this was mainly driven by the distribution, the increased food grain distribution through the PDS shops, the public distribution system. So consumption from PDS went up for everyone, not just for non-BPL households, since the government, so even for non-BPL households, the government allocated to all households regardless of their BPL status, and BPL stands for below poverty line households. So even though we see that there is some drop in terms of purchase from the market, but that got more or less made up by purchase from the PDS shops. Next slide, please. So this is an interesting figure where we first break up by PDS purchase, and then we show the total purchase from both the PDS and the market. And here we observe that while there is a marginal drop in the quantity of per capita consumption of wheat between the two periods, which are the last two bars in both the graphs. The drop is minimal primarily because of enhanced distribution of both rice and wheat through the PDS shops as part of the package. Now, we observe that as far as non-BPL households are concerned, per capita consumption of wheat increased by 860 grams. It increased by 360 grams for BPL households. But as you observe, even though the increase was higher for non-BPL households, the level was much higher for BPL households in both the rounds because because of the extra subsidies that were extended even prior to the pandemic. And something I would like to also point out that these are per capita quantities, quantity consumption, but even when we look at the number of households, we see that the 52% of households were purchasing wheat from PTS shops prior to the pandemic. This increased to around more than 70% in 2021 as far as wheat purchase is concerned. Rice is not really, doesn't really form the bulk of the consumption. It increased from 22% of households consuming rice to 29% of the households consuming rice from purchasing from the PDS shops. Now we also observed that, and these data are not shown here, in terms of pulses, consumption remained more or less stable, and both for BPL and non-BPL households, even though we don't really see much uptick from PDS shops as far as pulses is concerned. Next slide, please. Now, here we show the mean subsidy value of cereals, and this is per capita and per month figures. Now, one thing I would like to point out, 46% of the households in the matched panel bought food grains from the PDS shops in 2019, and that increased to 53.6%. And of that, nearly 50% were BPL cardholders. But as we saw, that even non-BPL households were purchasing from the PDS shops, and that was part of the increased subsidy that was offered by the government, regardless of the BPL status. And we see that the PDS subsidies were very pro-poor in nature. We see that and if you observe the lower gray line, that's the difference in between 2019 and 2021 mean subsidy value across wealth quintiles. So if you observe the poorest and then the poorer, which is Q2, and then the middle is Q3, and then the fourth quintile is Q4, we see higher per capita quantity of cereal consumption all through, and this is obviously backed by, which we saw which we see, and this is backed by increased subsidy availed for cereals in 2021. So we observe a very broad-based nature of the food support program that is extended by the government, and this also helped sustain consumption between the two time periods. But this is primarily limited to, our analysis is limited to Delhi region, so everything is confined to what we observe in this region. Thank you.
Thank you, Pallavi. This is really interesting, and I actually just want to point out that some of the drop in consumption may also be associated with the change in living structures during those times when people are not going to work, there are no transportation expenses, a lot of children switch from private school to government school, so tuition fees declined, private tutoring costs went down, and so on. So a lot is going on in these consumption figures in here, but it's reassuring to see that at least the food intake remained more or less stable. Okay.
Yes, and also there's a drop in purchase from like food, but like there's a drop in social functions. There's a expenditure on social functions. There's a drop in takeout or like, you know, food purchase when you sort of restaurant dinners.
Right.
So all those kinds of things actually went down. So yes, discretionary items, that was a huge fall.
Very interesting. Now, though, we come to the one of the gravest consequences of the pandemic that we see. And our next presenter is Dr. Manjistha Banerji. Manjistha?
Thank you, Sonal. So next slide, please. We will start by looking at children who are out of school. Normally, you would expect that that the proportion of children who are out of school is higher in the older age groups as compared to the younger age groups. But if you look at the graph on the right-hand side panel, you will see that the proportion of children who are out of school is higher in the age group of 6 to 10 years as compared to the proportion of children in the age group of 11 to 14 years. This is particularly so for girls. If we compare the percentage of children who were out of school during the baseline, which was conducted in 2019, with the percentage of children in 2021, we will also see that the percentage is higher at end line as compared to the baseline. So, for example, in the age group of 11 to 14 years, in the age group of 6 to 10 years at end line, we had about 6.5 children who were 6.5% children who were dropout in 2021. The corresponding percentage in baseline is 1.4%. Again, if we compare the never enrolled children for 6 to 10 years, this percentage is 4.3 in 2019. And the comparative percentage at end line is 5.9%. Now, it's not surprising that children between 6 to 10 years were the most affected due to school closure during the lockdown, because they could not get admission to school as they were closed. Next slide, please. Now, if as Santanu already mentioned the heterogeneous nature of the national capital region. If we disaggregate enrollment by location, where we have disaggregated it in terms of Delhi, other urban areas and rural areas, it's not surprising that Delhi has a better enrollment situation as compared to other urban areas and rural areas. Here, urban areas includes urban areas of Haryana, Rajasthan, and Uttar Pradesh. Likewise, rural areas includes rural areas from these three states, and Delhi is confined only to the Union Territory of Delhi. Between 6 to 10 years, just to highlight, never enrollment in rural areas was 7.8%. The comparative percentage in other urban areas was 4.6%, and in Delhi it was only 3.1%. Next slide, please. Now, we all know that schools were closed during the pandemic. We have done a rough calculation of the number of days of school closure between March 2020 and October 2021. Delhi has the highest number of days of school closure of around 585 days, followed by Uttar Pradesh and then Haryana and Rajasthan. Certain caveats are to be noted here. Schools did open briefly for in-person teaching between the grades, for grades between 11 and class 9 and class 12. In Haryana, Rajasthan and Uttar Pradesh, schools were also open for grades 6 to 8 before they opened for all. And the number of days of school closure presented here includes closure due to COVID as well as academic break. Next slide, please. Now, how did schools provide teaching learning when they were closed due to the pandemic? This happened through providing instruction through digital and non-digital means. So it was some form of remote learning. Now, if we further disaggregate the percentage, the enrollment status in terms of the percentage of children who had access to any form of remote learning, we find that only 50% of currently enrolled children had access to remote learning. Again, Delhi stands out as compared to the other regions. In Delhi, about 70% of children had access to remote learning, as compared to other urban areas where it stood at 56%, and in rural areas, it stood at mere 35%. However, quantity is not equivalent to quality. In another study where we spoke to parents from marginalized populations to see the effectiveness of remote learning, many parents expressed concerns about the quality of remote learning. Next slide, please. Therefore, to conclude, the findings presented here confirm the results that have been emerging from other studies as well, that there has been a significant learning disruptions on account of school closure, thereby pointing the need for urgent interventions. As schools have reopened post the third wave, we think that there is a need for efforts on two fronts. First, special efforts should be made to bring those children who are not part of the schooling system into the back into the school fold. This should be particularly done for those who are between the ages of 6 to 14 years. And second, and this has been widely discussed in the national media, is that rather than teaching to the syllabus, the focus ought to be to help children recoup the learning loss on account of prolonged period of school closure. Thank you.
Thank you, Debasis. Thank you, Pallavi, Manjistha, and everyone. We have presented a lot of different strands of results. So let me take a few minutes to summarize it. But while I do it, if you have any questions, please put them in the chat box so that we can respond to it and sort of carry this discussion forward. So what did we find? Okay, we found some dark clouds and some silver linings. Okay, let me start with the silver linings first. Number of things are quite impressive. First thing, okay, is that vaccination happens to be a particularly positive outcome that we find. There were initial hesitancy, there were initial fumbling, delays, and so on. But the vaccination rate in India has picked up sharply. And interestingly, we find that tremendous number of people have gotten vaccinated. I should say that the team and I have been doing some field work in rural areas in recent days, and we find that pretty much everyone we spoke to was vaccinated. So some of this data we present now is from August to November. If we go back in February, I think we're going to find an enormous level of vaccination. There is also a lesson to be taken out of it in the graph that Abhinav presented, which is that there were bimodal distribution. Either everyone was vaccinated or no one was. And that kind of tells you something about trying to reach the household, that once you manage to get one person, there is a good chance that other people will also get vaccinated. And this is something we might want to remember for future pandemics or future vaccination campaigns. The second piece of silver lining comes out of the fact that there is the employment has pretty much recovered. And this is something that's not only do we find, other studies have also found that there has been a substantial recovery in employment. Now here, I would like to caution us all in that India, countries like India, where there is very little support system for unemployed people, unemployment is not an option. And people actually generate their own employment and pick up whatever is available and just take it on. Okay? So in that sense, seeing employment recovery does not necessarily mean that it's the good jobs that have recovered, but nonetheless, there is an employment recovery. Okay. The third area of positivity is that although there is some decline in consumption expenditure, we do not see any decline in food expenditure or in measured things like consumption of wheat and rice. And here I think we need to compliment the government in the very rapid action in terms of expanding access to public distribution system to both people who are BPL card holders, that is below poverty line card holders, as well as people who are not below poverty line card holders. And in some states, even just anyone could go and actually buy food from or get the food from the ration shops. So all of those have provided a level of support to Indian economy that on which we can build the recovery. That said, there are also some real challenges that we will be facing. And I think 3 areas of challenge deserve attention. One, although our data just provide a brief support for the fact that some of the small business owners are no longer participating in family-owned business, I suspect there may be a large number of micro enterprises which actually closed and due to the pandemic, and restarting them would be very important for us to be able to reboot the economy. The second area that is worrisome is the long-term health impacts. We only sort of highlighted some of the treatments or lack thereof for major non-communicable diseases such as diabetes, high blood pressure, and heart attack. But there may be many other effects that we do not yet know and they haven't yet emerged. These have implications for both the health status of the country as well as for programs such as PMJAY, where if there is increased rate of hospitalization due to this lack of care, the financial crunch may be very high. So one of the things that we may want to think about is using some of the testing facilities and testing infrastructure that has been put in place to do a non-communicable diseases screening and treatment and invest in it at a priority level even more than we might have done otherwise in the absence of the pandemic. The third area, and this is, in my opinion, the biggest challenge and the biggest implications for the long-term future of Indian society, has to do with education. I was really struck by the numbers that Manjistha was presenting in terms of number of days the schools were closed. Essentially, the last 2 years are the lost years for the Indian population or children. And that impact is particularly large for children 6, 7, 8, 9. Okay, these are the kids who found it hard to get into the school. Once you cannot get into the school because the schools were closed, it was very hard for them to go and get their enrollment paperwork done. If they cannot enroll in school, they cannot get online teaching, whatever quality it was. For some of the older children, this were very difficult years, and there has been a greater dropout. So somehow or the other, we have to find ways of recovering this lost learning, bringing children who have been left behind back into school, making sure that remedial training is given. And this is the right time to think about it. It's beginning of March. School year will begin in April in Delhi area, in June in some of the other areas. This is where we can think about remedial training. I would also like to point out that some of the very good practices we had put in place in the past as a part of Right to Education Act, that children should be placed in age-appropriate classrooms, may need to be suspended for a little while until we can have some catch-up education. Because it would be very difficult for a 9-year-old to go to school, be placed in class 3 or 4 and not be able to read. Okay? So we really need to think about how we are going to recover some of this lost learning. With that, I'm going to end my commentary and open it up to the audience for questions. I know that there are several questions, and some of these questions have been answered while they were being put in place, but I think actually These are very interesting questions, and it may be worth sort of throwing it out because other people may have these issues as well. Okay, so for example, there is a question from Anil Sharma where he asked about issues of vaccine hesitancy. And I think there are some interesting answers coming from Santanu and Abhinav. Do you want to sort of talk about it?
Yeah, I think we did a study in 2020 December and early 21 January where we asked about hesitancy with the same sort of sample. And we saw about 40% hesitancy at that time. As Sonal mentioned, that there was initial level of hesitation that we all are aware of. So we haven't linked that study to this finding that we have now about their vaccination status. We can try and do that, what happened to the hesitant population, whether they are vaccinated now or not. So that could be done. Yeah.
There is a question from Bhavna Taneja where she asked about the information about class and region of residence for the respondents, the 14% respondents who were not aware of the name of the vaccine they received. Abhinav notes that this is something that we are still in the process of analyzing, but I actually wanted to make a comment on this one. Okay, you know, regardless of knowing whether the name of the vaccine, individuals manage to get the vaccine. And in some sense, I think it's the CoWIN app that sort of plays out there, where you get first vaccine, you get a message for your second vaccine, the second dose when you become eligible. And in some sense, people didn't need to know what they were getting because there was a record that already existed. And I think that might have made a huge difference in terms of people's being able to complete their second dose in timely fashion, and hopefully the third dose as we go along. The third
also,
question.
I'd like to add one point, Sonal, here.
Yeah.
So this is an interesting scenario where we can assume the official data to be the gold standard because of the mandate of self-registration or on-site registration. I mean, self-registration was relaxed later, which was a good thing. I mean, but there was some registration was required to get the vaccination. So that kind of makes it a very gold standard data and sort of reflects the actual level of coverage in the population. So, yeah.
I actually also think that maybe we want to think about it for future on childhood vaccination, because as a parent, I can assure you that I could never remember when my child was due for the next vaccine. And, you know, for a privileged group like us, our doctors often remind us, but this is not what everybody else does. So registration for vaccination and text messaging to remind people that it was time for the next dose of vaccine might be something really worthwhile doing. And I understand there are several experiments where it's actually already being done. There is an interesting question from Mr. Sekhar, where he asks, what's the reason for higher positivity rate, test positivity rate observed among the richest class? And Santanu, do you want to take this question?
Yeah, so actually we have been sort of trying to find an answer to this question for the last week or so. So I think there could be a couple of explanations. I mean, one could be that the poorer population and people from, we have seen that in rural area also the positivity rate is lower. That could be that in some cases people may not have access to RT-PCR, but only access to rapid antigen test, which is known to have lower sensitivity. So that could be one possible reasons. And also there's some change in guidelines, ICMR guidelines after Delta wave. So which sort of tried to optimize the use of RT-PCR and increase the use of rat tests. So that could be one possible reasons. Other is that there's some studies which shows that like people who are exposed to many pathogens throughout their lifetime, I mean, living in not so hygienic conditions, etc. So they may already have developed some kind of resistance to COVID. So that also could be one of the explanations, but still we're not fully sure why we see this result.
Yeah, this is a really puzzling finding, and I think this is going to require looking at other data sets, other surveys, and so on, to see if what we are finding is something unusual and unique. We have a few open questions. There is an interesting question that is a longer one that I won't read out fully, but from Mr. Govindapuram Suresh, which talks about a lot of issues with data reporting in terms of underreporting, not reporting of positive cases and deaths, and so on. If there is one of the lessons that we are going to take away from at the end of this pandemic, is actually a greater belief in data, because this has been one of the few instances that the world has seen where actually data has guided our expectation, right? So India imposed a lockdown before a significant rise of COVID cases in India. Okay, and we did that based on some of the modeling, some of the experiences of other countries, and so on. So I think that if I can say anything that would make sense out of the current pandemic, is that we need to develop better registration systems. Our vital registration system needs to improve. Our overall data collection systems need to improve. It's also been a challenge to people like me and Santanu, who are very used to doing face-to-face surveys. And suddenly we realize that this is not something that can be done under all circumstances. So figuring out how to collect data under adverse circumstances where travel is not very easy and finding people is not very easy is again something that's going to require substantial amount of thinking, work, and perhaps some smart experimentation and planning. But your point is very well taken, that somehow we are seeing a lot of either underreporting, anomalous data, and a variety of challenges associated with the data. I think you also had another question on the trends, whether year-wise or monthly. And because I don't know which specific graph you are referring to, I would say that most of our trends that we talked about are before the pandemic struck and post-pandemic, with the exception of one graph, which was on the employment drop during the first and the second lockdown, and those are to come from the monthly data.
Yes, ma'am. There was in the above you mentioned that years, like 2009, like 2009 to 21, but in the down, it's instead of months, it's showing that years, ma'am, 1903, something like that.
Okay, so,
right. So that would be March of 2019.
Yeah,
like both male and female are going in a parallel, like the gap between the male and female trend is very much parallel, man. So that's why I got confused.
Yes, and it was, what we found was that basically when the lockdown occurred, first lockdown, pretty much nobody could work. Okay, men's work participation fell, women's work participation fell. Men's actually fell more than women's, largely because there were more men who were employed. And moreover, women were often working on family farms and taking care of the livestock, which allowed them to continue even during the pandemic, which they couldn't continue. For men who were on salaried work or casual laborers couldn't continue. So while both the trends were parallel, we see somewhat of a greater drop for men than for women. Okay. Thank you.
Ma'am, one more thing I have added there, there is a difference in reporting of the cases. Like if you see the US, UK, you can see the number of cases as well as the deaths in terms of, it was actually a drastic increase every day. I think maybe the reporting is fine. I don't know exact reason, but if you see that like China or Japan or other countries, we will be it's not that much. So maybe is this institutional factors or the trust or really they have medical facilities like that. So can you elaborate on that, ma'am?
I think we have actually three different groups of countries here. Okay, there is India, then there is US, UK, and then there is China and Japan, and all three have sort of a different patterns. With both US and UK, there were sharp increases in infection rate. US still remains, is barely coming down. They also experienced substantial number of deaths. China and Japan were actually able to control it much more so, and they have very relatively fewer number of cases, fewer number of deaths. Okay. And India sort of falls in between in terms in that we have very large number of cases, but not nearly as many deaths. I think this is a puzzle that we are going to be puzzling out for years to come. This is going to be the demographer's haven, when we start looking at a variety of data sources, and perhaps we might not have a good answer to estimates of, whether India really had low number of deaths, or there were a lot of deaths that went underreported. I suspect we're going to have to wait for census to come through before we get a much better sense of these. Okay. I would say one thing, however, that there was clearly some hesitation among people in particularly the early periods in reporting the cases as well as deaths because of strong stigmatization and requirement for quarantine. So
yes, thank you so much. Actually, I was wondering that, was trying to read but I could not get exact answers.
I know. I think sometimes you feel like we are all sort of fumbling in the dark, right? Without data, it's very hard to answer these questions. We can speculate, okay? But yes, we don't have very good data. And that actually brings me to the next question on my chat here by Kirti Nakare. Okay. Did you note any orphans? Let me just say that our sample was very small sample, and it doesn't allow us to sort of get a good handle on some of these very rare events. My hope would be that some of the larger sample surveys, when they take place, we will get better data on some of these topics. So unfortunately, in this case, we don't have any ability to provide good answers to that question. Are there any other questions, comments? Do any of the panelists have anything they would like to say? I think there was a raised hand somewhere that got lowered.
Perhaps Amrita has a question. She raised
Amrita?
hand.
Do you have a question you'd like to ask? You can unmute yourself.
I got it clear.
Okay. Well, thank you very much. If there are no other comments, I'd just like to make a short comment before I thank you all. I think we have been through a traumatic experience as globally and in India, and we are beginning to sort of hoping that this wave is subsiding, we will not be experiencing another major wave. It's very hard to know what it would look like. But there is one lesson to be taken out of this, is that the world will continue to experience disasters one after another of some kind or the other. And perhaps this has given us a better appreciation for disaster planning, both in terms of collecting appropriate data, finding ways of providing social safety nets, and responding in some sensible manner. One of the best things that happened in terms of for India was that we were able to provide some of the subsidies and transfers for people for whom we had information about who they were and where their bank accounts were. Okay, so we said we could send money to Jan-Dhan account holders, we could send money to PM Kisan. What we could not do was identify people who were the most vulnerable, who were kind of marginalized, who did not have any of participation in any of these registries, such as migrant workers. So as we go along, I think we're going to have to think more intelligently about developing ways of providing social safety nets. And we may need to rethink our traditional assumptions that people who are born in poverty will remain poor, and we can identify the most marginalized people based on their caste, background characteristics, I think we will begin to discover that the vulnerabilities occur to people who were not born poor, and there may be we may need to figure out better ways of devising social safety nets. Thank you very much. With this, I am going to thank all the participants and close this and let all the people in India go to their dinner, people from abroad, good day, and thank you very much for joining us.